All right, welcome back, everybody. This is Justin here again with Bluebird Health, and I am very pleased to briefly introduce. I'll let our guests do most of their own introducing, but we have several representatives here with us from the National Association of Home Care and Hospice. We have Davis Baird, the Director of Government Affairs, Calvin McDaniel, who focuses on the home health and hospice legislation, and Mary Carr, the Vice President of Regulatory Affairs. So thank you guys for joining us today. Very pleased to have you with us. I'll let you guys go ahead and take it from here.
Awesome. Thank you, Justin, and hello to everyone. I'm Davis Baird. I am, as Justin said, Director of Government Affairs at NAC. I focus on the hospice and palliative care issues, joined, of course, by Calvin and Mary. Calvin's going to be our Svengali with the slides here. So, Cal, could you share the slides on your side, if you don't mind? Perfect. And then let's get that slideshow maybe version going. So, perfect. Thank you so much. Here we go. All right, wonderful. So again, thanks so much for having us. It's we're DC based, a little later for us over here, but never too late for our friends in Idaho. We're going to be talking to you guys today about what's happening with some federal policy, how it's impacting care in the home and what that may mean for care models of the future. So next slide, please. This is just the objectives. In the interest of time, I'll just skip over here this quickly. Folks can read this later. Kyle, you can go to the next slide. All right, cool. So we're going to get into some wonky details here, some acronym soup shortly. We are from DC after all. But I wanted to just kind of start by acknowledging that generally the broader sort of health policy conversation in DC, where we sit, on the federal side right now, is surprisingly and positively conducive to really supporting our field, our industry of home and community-based care. I've got this picture up here because I kind of see this as like a quote unquote back to the future moment. We've got the DeLorean up on the Capitol wall here. I thought this was a cool symbol for all this renewed energy in Washington right now around what is really at its heart an old concept, right? That's the concept of shifting more care into the home, coming up with new models of home and community-based care, especially for folks who are seriously and chronically ill. Next slide, please. And all right, so what are the macro forces driving there's all this policy interest? There's tons of them. It's not one or two. I think there are a couple main ones though. First, of course, it's math, right? Basic demographics. We've got more people living longer with more serious illness, more functional impairment, and most of them prefer to age and die in their own homes and communities. You see this time story on the left side of the screen here that kind of reflects that. Then, of course, the pandemic just absolutely supercharged interest and awareness of care in the home across the entire continuum. You've got two stories on the right here kind of reflective of that, just the general push, some stuff on telehealth, which we'll talk about a little bit more in detail later. So these two factors, again, I think they've really, put us in a place where we're kind of an inflection point here in this country where home and community-based care, all the great care that you guys are doing out in Idaho, it's really in the spotlight like it hasn't been before. Next slide, please, Cal. So, all right, so we're in the spotlight. What is it showing? What's the current kind of state of play in the care at home industry right now? On this slide, you're going to see a short list. It's not exhaustive, of course, but I think it gives us a good sense of some of the major winds that are blowing around right now. Top of the list, undoubtedly, workforce challenges, totally unprecedented right now. Care in the home providers have really never had to contend, our members at NAC have never had to contend with the labor market like this. We hear every day this is the top issue. It's going to remain so for the foreseeable future. So top of the list here for sure. Next up, I put consolidation on here. I think it's certainly true that, care in the home fields, Medicare home health, hospice and palliative care, non-medical home care, they all in the aggregate remain quite fragmented, especially compared to some other sectors in healthcare. But it's also true that there's tons of consolidation happening right now. Lots of mergers and acquisitions going on, including amongst some non-traditional players, Amazon, Walmart, CVS, right? Best Buy. We don't quite know how this is all going to shake out in the end, what it means for the industry at large, but these are huge influential stakeholders. And so we've got to engage here and keep track of what's going on. Third up here, I've got technology. Obviously, we mentioned telehealth already. That particular technology has been a game changer the last couple of years. It's going to continue to be. But it's not just telehealth. I think other advanced technology tools, things like data analytics, artificial intelligence, next generation EHRs that actually talk to each other, remote patient monitoring. All of these things are going to be playing an increasingly prominent role in the care models of the future. It's good. It's also challenging because there's a lot of costs and learning curves associated with those as well. Increased government oversight. This is definitely a powerful trend for us right now. It's kind of always, it's an evergreen one, not necessarily a pleasant evergreen one, but it's likely only to increase as more and more people are utilizing home-based care services. And the federal and state governments are spending increasing amounts of money on home and community-based care and investing heavily in new models of care. It's almost a law of nature, right? You're going to have more sort of oversight actors sort of looking at our space. Finally, here on this list, new value-based care models. I kind of know that's what the heart of this conversation today is about. This is where some of the most exciting, but I think also nerve-wracking stuff is probably happening for people in our field. Hands down from the policy side, lawmakers, CMS, they want to incentivize more care in the home to shift to these new value-based models. That can mean, great opportunities for innovation and new service delivery methods, but we also have to recognize this is a massive shift. It can be a disruptive shift. So that means it needs to be undertaken thoughtfully, gradually, so that, well-meaning providers across the country that, might be smaller or not as rich or capitated or sophisticated, that they're not left inadvertently on the sidelines of this shift to these new models. Because we've seen that happen a little bit in the past. We want to guard against it in the future. Next slide, please, Cal. So that's just kind of a quick overview, frame up, the background forces. We're going to dive now into some more of the specific policy priority areas that we work on sort of in the day in, day out. These are things that are currently top of mind for care in the home stakeholders, our members, but also policymakers here in Washington. So I'm going to turn it over to Cal here because we're going to be starting with Medicare home health.
All right, thanks for that, Davis, and thanks to everybody on the other side of the screen for joining us today. I want to dive in on the Medicare home health stuff that we've been really working on. Top of the list, there's the Preserving Access to Home Health Act, something that if you're a Medicare home health provider, you've become aware of quite quickly and very recently. This bill is the response to what CMS has proposed in their annual rulemaking. They came up with a 7.69% cut overall in the name of budget neutrality, a requirement CMS has by the hands of Congress, but not necessarily carried out the way that we think Congress meant in the first place. They came up with this budget neutrality requirement in advance of putting PDGM in place. The idea being there that they're going to change the payment system, but they don't want to, damage the payment system financially through that transition. So they came up with this budget neutrality requirement to make sure that spending was steady across that from pre-PDGM to post-PDGM. Unfortunately, CMS has carried that out in a way that we don't agree with, and I think everybody on this call would not agree with either. So the crux of this is we came up with kind of a predecessor to this language that was very technical and very specific in doing X, Y, and Z ways. But the lead champion on this bill came up with a different idea, saying, let's just freeze the payment rates in place for 3 years through 2025, and then have some more data to work with, see what CMS is looking at, check their calculations, make sure the policy is actually being followed through as it's intended to be, and not kind of a big cut to the industry as a whole. So that's out there right now. We don't expect to see anything happen with it the next 2 to 3 months. We have the election upon us right now, but maybe late November, early December, we could see it be put into some sort of end of the year Medicare package, maybe a spending package, whatever comes together. We're hoping to get that. And at that point, and again, that would just freeze in place the payment rates as they are right now, with the exception of the annual market basket updates. Another bill, Choose Home Care Act, came on our radars about 1.5 years ago. This is what we think of as maybe the biggest improvement or broadening of the benefit since its creation. Essentially, it would allow for a set of services to piggyback on the traditional home health benefit as it is right now. So think things like increased personal care services, meal delivery, home modifications, respite care, non-emergent transportation, services that would allow for people that need just a little bit more help to recover at home to be able to do so. Some people have labeled it a sniff at home. That's not exactly the intent to it, but there would be some overlap in the patient population there, albeit a very small overlap. That one's really, excuse me, a really exciting bill for us. Something that we always see as an offensive move for the industry. It did unfortunately take somewhat of a backseat to the Preserving Access bill, largely because it's such a significant cut we were dealing with, but we would much rather be pushing for an expansion of the benefits as it is. And then lastly, the HEAT Act, or the Home Health Emergency Access to Telehealth Act, that came by way of the pandemic. Suddenly we had a lot of people that wanted to be at home, wanted to get out of the hospitals and the nursing homes. And we had a lot of providers that wanted to be able to utilize telehealth. You had patients that didn't want people in their homes. You had providers that had the opportunity to use telehealth, maybe facing some staffing shortages on their end. So telehealth could be a way to alleviate that. So we came up with this bill, at least this idea to expand telehealth within home health. I shouldn't say expand, allow for it within home health. We met quite a bit of resistance from Congress, though. There was a lot of concerns about fraud and abuse of it. Ironically enough, we just saw a report come out of OIG that basically no fraud or abuse was found from telehealth through the pandemic. So wish we could have had some more success there early on, but all that to say, what we originally proposed to them got watered down and cut back significantly. The bill at this point would allow for telehealth in home health only in pandemics, only if the Secretary of HHS and CMS want to do it. And then some other guardrails around it as well. Certainly not what we and a lot of providers nationwide wanted it to be, but it is the best we could do with the opposition we were facing. Just to round out some of the proposed rule, really included the slide as an FYI and just kind of have the numbers of its impact in a kind of helpful and condensed format for you. I do want to highlight the second to bottom one. 26 states and territories projected to have half of their providers underwater. Very scary to us. It's been a big talking point on Capitol Hill. But again, just some data for you to have at the ready. And with that, I will turn it over to Mary for some further discussion on the rule.
Can you go back to the last slide? Because I just want to talk a little bit about something so people understand what you need to understand. I'm going to tell you how at this point, because this is very concerning, as Calvin had said, and this relates back to his piece of legislation with preserving home health care. And that is CMS's 7.69% is a permanent decrease in the standardized base rates. And they have come to this conclusion, and this is in addition to some additional temporary decreases that they are going to apply later down in the road. And this came about because when CMS did the PDGM rates, when they set them, they included in the base rate a 4.3% reduction in payments to accommodate what they call assumed behavior changes that they anticipated how agencies were going to respond to PDGM. Congress ultimately required CMS to do this. And so it is, when they talk about the budget neutrality, what the statute requires that CMS annually look at these rates from 2020 to 2026 and evaluate the difference between what they perceived were changes and what the actual changes were, and reconcile that annually. That is the budget neutrality that we believe Congress is requiring CMS to do. What CMS did, though, however, is they took data from 2020 and 2021, the PDG claims data, they plugged it into the old model, the old PPS model, and did a simulation of what the cost would be if, in fact, that model was still in place. In other words, if PDGM did not come about. And in the aggregate payments that they calculated by doing this was a $2 billion reduction. meaning that CMS believes agencies have been overpaid by $2 billion since the initiation of PDGM. And this is where all these cuts are coming from. And that CMS says that agencies owe that money back, and they are going to recoup this. Now, obviously, we have some very, very significant concerns with this. We don't believe that CMS is following the law. We don't believe that that is required. What they did was not budget neutrality. It was really rebasing. And even if we did agree with what if we did agree that this was an accurate budget neutrality approach, that CMS's methodology does not make any sense, that they took PDGM data and threw it into the old model. We are concerned also that CMS used 2020 data. We know that was a very aberrant year. And we're very concerned that CMS has not really been very transparent with some of the data and the information and how they calculated these rates. So I just wanted so you understand where these numbers are coming from and how this could very much, leave the industry, destabilizing the industry. And this relates a little bit back, if you want to go to the next slide, this relates a little bit to what I'm going to talk about here. In addition to payment cuts, CMS also in this rule is proposing to require that agencies collect the OASIS data set on all patients. For those who don't know what the OASIS is, it is a standardized data set. It is collected currently and reported on all Medicare, Medicaid, and Medicare Advantage patients. It's part of a comprehensive assessment, and it's collected at different time points throughout the patient's stay. The most comprehensive, or the one that has all of the data items, is the start of care. And agencies have reported that this takes anywhere from 1 hour to 1.5 hours to complete. So CMS's proposal to have agencies collect this on even more patients is even going to be more burdensome than what's already exists. Now, CMS over the years has requested information regarding this proposal. In request for information, they've done that twice. And we have consistently gone back to CMS and said, no, this is too burdensome. You have not, sufficiently given us reasons for why you need this information, certainly to support the burden that it's going to cause. But CMS now is proposing this. And if it is finalized, even by CMS's estimates, it's going to be a 30% increase in burden and estimated clinical cost. It is clinicians that collect this information, nurses and therapists, and CMS typically underestimates what burden is. And then your annual cost is just what these are CMS's numbers too. Why this is important is when you put these together with the rate reductions, it really doesn't support the value of home health care. At least the regulators don't seem to be supporting it. We talked about how certainly with the public health emergency, the value of home care is growing. We recognize that's where patients want to be. Patients do better. Hospital at home has proved that. This is where the future should be going. But our challenge is our federal regulators really don't seem to be supporting that. And we see that in our rate reductions and proposals for burden. So I think that's important to keep that in mind, because when we talk about moving forward with home health and where home health is going to go in the future, we really need to understand what the challenges are from a regulatory perspective. Next slide, please. Now, the one good thing that we do know is that CMS is expanding the value-based purchasing program. And we took this as a positive because in the original program, CMS, this model saves significant amount of money for the Medicare program. Patients' quality of care improved, patient satisfaction was good. So it really showed that home health has a very important role in the continuum of care. And in fact, they can be very instrumental in saving healthcare costs. And this is why CMS wants to go, this is through the CMMI, want to apply the value-based purchasing program nationwide. So it will be expanded beginning January 1st of 2023. Very similar to the original demo. Calendar year 2023 will determine payments for 2025. Payment adjustment goes up and down by 5%. Agencies will compete on quality measure performance, and there have two cohorts, small and large, very similar to the original demo. However, these smaller, large cohorts are being applied nationwide as opposed to within the individual states. And there is some concern that the large cohort are going to have over 90% of the agencies, and the variation within that is going to be, I don't know how CMS is going to control for that, but that is something that bears watching, this very large cohort for which agencies are going to have to compete against, and there's going to be significant variation. The other thing we want to keep an eye on is health equity concerns. And whenever you have a payment incentive, you are going to be concerned about cherry picking. Are agencies not going to accept patients that are very complex? Are they not going to accept patients that may have social determinants of health that may have a negative impact? If you looked at the evaluation report, the last evaluation report from the original demo, CMS already started to show some despair. I mean, the researchers already started to show that there were some disparities within the Medicaid population. The Medicaid population did not have the reduction in hospitalizations the way the fee-for-service patients did, nor did they improve in all the functioning measures as the fee-for-service patient did. And keep in mind that the savings majority in the original program came from reductions in hospitalization. So there's already some equity concerns that we are going to be watching, but this is one positive thing. It is again concerning because when this was proposed and finalized, we were in a different world. We didn't have a rate cuts. We didn't have a workforce shortage. And we do know that agencies that were very successful under the original demo did spend a significant amount of resources in working and improving quality, working on the quality measures, doing education, those types of things. Without staff and money, it's going to be very difficult to be successful under this value-based purchasing program, but we will be watching it and hopefully some good will come out of it. And I'll turn that over to, I guess.
That's me. I'm up next. Perfect. Thank you so much, Mary. It's a really great overview. Sobering in some ways, exciting in others. You know, like we said at the beginning, those new value-based models, there are opportunities, but also challenges associated. So we're going to move on here to hospice and palliative care. That's the area that I focus on at NAC. Some of the priorities. We're going to start here with this slide on the legislative side. And first up for us on this list is this is not really something that's, you know, directly related to future innovation in a one-to-one way so much, but it is a threat to the existing hospice care model. And, you know, we can't innovate if what we already have sort of is being attacked. So what I'm talking about here is the need to guard against an aggressive payment cut to hospice in the form of a recommendation from the Medicare Payment Advisory Commission to Congress to cut the hospice aggregate cap by 20%. Folks have probably heard about this recommendation. It's been out there for a couple of years. There is some interest right now amongst a few stakeholders on Capitol Hill in advancing this beyond just a recommendation. So that's why I put it at the top of the list. We at NAC strongly oppose the idea. We think it will negatively impact access to care for certain hospice patients, primarily those who have illnesses where it's much harder to predict their prognosis. So, you know, when they're going to die, what their decline trajectory is going to be like. You know, sometimes those patients who tend to have non-cancer diagnoses live longer on hospice, including sometimes longer than 6 months. And of course, that costs Medicare money. So that's why MedPAC was interested in this idea in the first place. It's why Congress is interested in it. Again, follow the money. But it's really a bad idea. It's a bad policy solution. It's really an overly blunt tool that would punish good hospices and reduce access again for some of those most vulnerable patients and families out there. So that's kind of top of the list because it's an immediate threat in front of us right now. Next up on the list, we need to absolutely bolster the hospice and palliative care workforce, right? The primary legislation that's out there right now to do this is the Palliative Care and Hospice Education and Training Act. That's PCHETA. This is a bill that's been cycled through a few Congresses. I think it was first introduced 10 years ago. It would provide funding to increase education and training for specialty providers in this space. A lot of that money would go to institutions of higher learning in the form of grants. So a really important bill. We really are hoping to get it over the finish line this year, finally. Then finally here, this is kind of more in line with our overall topic today about new models. We are also pushing for Congress to require the Center for Medicare and Medicaid Innovation, CMMI, which Mary mentioned in the context of home health. But we want CMMI to develop and test a community-based palliative care demonstration model that is upstream and separate of palliative care that's delivered under the Medicare hospice benefit. There is a bill out there, the Expanding Access to Palliative Care Act. It's led by Senator Jackie Rosen from Nevada, that would do just this. And really the impetus behind that legislation is, of course, that, you know, we all know, I think I'm preaching to the choir here, how valuable palliative care is for patients and families, oftentimes how it can save money for the system. We also know that it is not at all adequately reimbursed by any government payer, really any payer at all for that matter. So we need a demo to test a much more robust payment and delivery model that can serve to really show upstream palliative care's, community-based palliative care's value, which will hopefully eventually pave the way for more permanent Medicare coverage of this really valuable care. And Cal, can you go to the next slide, please? Perfect. So just quickly moving on, that's the legislative side. It's where I focus most of my time. On the regulatory programmatic side here, we just talked about CMMI. Again, they're the most important sort of government body when it comes to new models of care in home and community-based settings. In this space of serious illness, in addition to any standalone demonstration that we just talked about, like in the Rosen legislation, we're also working with them directly to figure out how best to thread palliative care throughout all of their models, all of their demonstrations, any of those that impact people with serious illness. And we're doing that because palliative care is this interesting thing, right, where it's really both a type of care, a specialty type of care, but also a philosophy, an approach to care. And when we're talking about that philosophy of palliative care and, you know, looking at its real basic fundamental service components, you know, advanced care planning, goals of care conversation, symptom assessment, those can be and should be weaved into all different types of care models. So cancer care models, kidney care models, primary care models. Who are the experts at doing palliative care, though? It's mostly home and community-based providers, hospices, primarily home health providers. So that's what we're working with CMMI on as well. Finally here, along those same lines of threading palliative care, we've been working on some other ways to better integrate palliative care into the Medicare home health benefit, specifically by modifying the home health manual such that a skilled need would qualify someone for a home health service. So that works really kind of still in its earliest iteration, but wanted to flag it for folks so that they can be on the lookout for more from us later in the future there. I'm going to turn it back over to Cal to discuss some workforce policies specifically.
Yep. So workforce, obviously, kind of the big elephant in the room here for everyone, was a problem before pandemic. That just kind of poured gasoline on the problem. Workers can go get more money everywhere. You guys know this. And we have these hard times based on payment rates. Medicare is one thing, but when we look at Medicaid, I doubt anybody on the call right now that does Medicaid is, you know, happy with those reimbursement rates. So looking at Medicaid payment rates and the private insurers, you know, that's frankly we're going to need to start out and trying to get some more money out of them to pay workers more. Simple supply and demand in a sense. Other things we've looked at, consumer tax credits. There's a bill floating out there that was at one point included in the Build Back Better package, what was going through Congress last year, ultimately got stripped out, but the Credit for Caring Act would allow tax credits for family caregivers. So that's one option on consumer tax credit. Another one that we've talked about, try to get some traction with, would be focused more towards tax credit for the consumer themselves. So if you're the recipient of care, you could get tax credit to help offset some of that expense. Another way to help shore up the workforce, think GI Bill type programs or student work study type programs, essentially getting credit for being a caregiver. We've seen, I think Jackie Rosen actually did a bill on this in the past, but a student care corps aid type program hasn't picked up a lot of traction yet. Be curious to see if they continue to push for that or not. And then lastly, employer supports through loans, grants, I think paycheck protection type things, other small business administration type loans or grant programs to help essentially increase the compensation for the workforce. Now, as far as home health trends, we've seen a big change the past few years. The pandemic obviously really pushed us in that direction. You had the people that want to get out of the nursing homes and hospitals and institutional settings. And the home stood ready. Home care workers were ready. Providers were ready. We've seen that sort of shift maintain, at least the desire for it. We've seen some programs such as the hospital home waiver come into place. We've seen some private insurers pick up on that. We've seen telehealth expansion. We've seen a lot of new innovative companies come into this space. Think groups like Dispatch Health or getting another one, but groups that are doing care on demand in the home, groups that are doing in-home lab testing. The portable diagnostics have already been in place, but we've seen some growth in those types of companies as well. And we've seen the investor class really get inside that stuff too. And lastly, merger and acquisition. I know Davis talked about this a little bit ago. Traditionally, we think about that as providers in the M&A space, but that's really grown to the tech companies, some of the other vendor type companies. We just saw Signify Health, a value-based company out of Texas, get bought by CVS, I believe. So there's a lot of M&A activity that's much broader than what people traditionally think. We have seen a decline in the provider-based activity this year. It was on record pace the past 2 years, and I wouldn't be surprised if we see that return. But for whatever reasons, it has slowed down this year. I'll turn it over to Mary now, I believe.
Yeah, thank you, Calvin. Yeah, I just want to, we certainly can't talk about the future of home care without talking about the growth for Medicare Advantage. And we know that the plans have various saturation throughout the country, but they are growing all over. Currently, 45% of Medicare beneficiaries are enrolled in MA plans, 55% in fee-for-service. However, by 2030, it is projected that that a little over half of Medicare beneficiaries will be enrolled in MA plans, and 99% of them do offer at least one supplemental benefit, so they can be very attractive. And I'm sure you've seen all the ads, and they continue to be very aggressively marketing their plans. However, next slide, please. We do have issues, and we are not alone in these issues. Payment rates are low, delayed authorization, utilization is very controlled, rigid medical review. Home health agencies don't have a lot of leverage with agencies because there are a lot of us, and these, agencies don't have a lot of leverage with the plans because the plans tend to have a very sort of, they pay, by cost per unit. It's how much per visit, how many visits can you give me? If you don't want to work with them, then they'll go next door and find an agency that they can work with. So agencies that try to be very sophisticated and use sort of a value-based approach, they do not seem to be interested in. And one thing you have to keep in mind too, relative to the cut in rates, that most agencies are subsidizing these low rates by Medicaid and MA plans through some of the margins that they receive from Medicare. So Medicare has been, and this is not unknown to CMS, everybody knows that the only way agencies can take care of some of these MA plan patients is because they also have at least an equal or higher mix of Medicare patients. They accept these patients from the referral sources because they want the referral sources to also give them the Medicare patients. If they continue to cut Medicare the way they are doing, I don't know how agencies are going to survive. The agencies won't even be able to accept these patients with their low rates and some of the things that they do that make it very difficult to work with them. The good thing is that we are starting to see activity at the federal level, GAO and OIG reports that are starting to report some negative findings on these MA plans. And so they are starting to look into it, and hopefully we will see some improvements. And we know that CMS issued an RFI seeking input from stakeholders. And of course, we submitted comments on that last week. So hopefully we'll see some movement and something where providers and these plans will work a little better together, because the additional growth is very concerning for home health.
Great. Thank you, Mary. It's a really great point. I think you're exactly right. There's so much momentum behind MA, and there is some promise there. It gets a little difficult when you get to the on-the-ground realities of the partnerships with providers for some plans. So we got to make sure that policymakers understand the full spectrum there. So I'm going to talk a little bit about sort of this concept that has been sprinkled throughout, I think, our discussion, this care continuum, right? So as I said before, we are undoubtedly just moving to this place where policymakers at the federal level especially are wanting to incentivize new care models that include sort of collaboration and integration of across this care continuum. So across different provider types, a seamless experience for a patient and family. And so I really think the future is going to be one where it's in the best interest of home-based care providers of all kinds to be reaching more outside their own walls, working more closely with other entities that are involved in the care of the patients that they serve. So this includes primary care, perhaps, at the top of the list, but specialists, as well as non-medical community-based organizations who have expertise in social services. I think that last group is especially important given the growing policy emphasis on health equity. And I know that we all, to one degree or another, work with these groups already. I'm just reading the writing on the wall from the policymakers, and I think we're going to have to formalize those partnerships in a much more robust way than we have had to in the past. I also think we're going to see some more policy action supporting this process of navigation for patients and families across these different providers, and really over a longer time horizon than, say, traditional care coordination or care management models that exist now. CMS especially has been pretty vocal about their interest in this idea of a trusted single patient navigator. So I wouldn't be surprised if we see them put a little more shoulder into that idea, as far as requirements or payment in some of these programs before too long. Last thing I'll say about this issue is that one of the key ingredients, like a foundational requirement for these more robust collaborations, is going to be easier data exchange across these silos. Of course, not at all what we have in our current system. There are so many different systems that, EMR systems that don't talk to each other or can't talk to each other. That status quo absolutely has to change. But we're going to need the government support. We need policy support to build out that infrastructure and some of those tools to do that. Next slide, please, Cal.
Before I go on, did you make that picture?
I did make this picture, yes. I am a child of the 90s. I love the Teenage Mutant Ninja Turtles and the Power Rangers. So home-based care on the left here, hospice home health, all our new friendly partners on the right, breaking bread. Yes.
As a fellow child of the 90s, just phenomenal. Very proud of you. Very proud.
Love it. Okay, so this slide, another future policy trend, and Mary touched on this a little bit. This might be the most important area, of all for our field, health equity. This administration in particular really focused on beefing up requirements and policies to address health disparities. And those are coming our way in the home and community-based care field as well, in the near and long-term future. And I think the policy area the arena where this is going to show up first is likely in the realm of quality measurement and data reporting. And we actually already have some specific recent policy examples of CMS's move in this direction. Again, Mary talked a little bit about this in the context of the home health value-based purchasing program, but maybe even more directly relevant, in this year's hospice and home health payment rules, CMS included a number of questions it wanted providers to answer about how they're engaging in activities to understand and address disparities amongst their populations. But not only that, also what they may be doing internally as a business to make themselves more attuned to these health equity issues. They also were seeking feedback on a specific proposed composite, quote unquote, commitment to health equity quality measure that could be potentially used in future reporting programs. So, these aren't just ideas on a whiteboard somewhere. These are real steps that they're taking. And health equity in general, of course, is again absolutely a huge priority for this administration. Now, looking a little bit even further down the road, I personally think that CMS is going to go further than just sort of attestation style metric reporting. I think that we're going to see providers in our space. We're already seeing a little bit of this on the hospital side from CMS, but in our space, eventually, we may be required to perform more robust or partner with others to perform much more robust social determinant of health screenings and assessments. And those might be, accompanied by requirements to actually make sure that if you screen for a social need and it's identified, you're responsible for closing that loop and referring it to a community-based organization that can help address it. I think we're moving in that direction, honestly. So, it might not be next year, it might not be 5 years, but sometime down the line, I think we're going to see some requirements there. So the takeaway here is invest in those health equity strategies. It's of course the right thing to do, but as I said, I think providers are going to be mandated to be doing more in this space in the coming years. And I think we're about to wrap up, but Cal, you're going to cover our last couple slides here.
We are an advocacy organization first and foremost, so I do have to put this in here. You guys do a really great job, generally speaking. You have some key members of Congress, so you're in a fortunate position there. But I do have to encourage you to maintain your advocacy efforts. Easiest way of doing that is through virtual advocacy. We send out these action alerts, what's the right word? Not frequently. Throughout the year, whenever we have a hot topic issue, getting some attention in Congress. So pay attention to those, use those. All you have to do is put in your name and information and it sends a message automatically. If you're able to get to Washington and meet with the legislative staff for your elected officials, that's great. That's just about as good as you can do. Meeting with the district staff is very good. They just tend to be more casework focused. They're not so heavily involved in lawmaking. So that's why I say the Washington staff is just a step ahead in preference. We are doing a fly next week. I think we've got at least one, if not two people from Idaho coming. So we're excited to welcome you then. Otherwise, any opportunity you can get in front of your electeds, if that's going to be like the county fair or if they hold office hours, or if there's like a coffee with your congressman, whatever it is, take advantage of that. Get a face and a name that they can associate with home care, with hospice, and they will likely be a lot more receptive and conducive to our issues. Last one I really want to highlight is the home care visits or ride-alongs. Some of our best champions in Congress have come by way of doing one of these. They might not have really had much understanding or thought as to what home care does and what it means in their communities. The moment they go on one of these, though, they instantly flip, and they can be our biggest champions. They get it, they understand, and they see the value, and they want to be helpful. So if you can get them out on one of those, they always are very well received. So I encourage that. And lastly, we don't see this as often anymore, but op-eds, they can still have a place in advocacy. So something else to keep in mind. And that's it. Contact information for us there. I think these slides can be distributed to you all. We've forwarded them out. Email us if you have any questions, concerns. We're happy to help. Happy to be a resource for you all.
Right, so it looks like we've slid in here just 2 minutes to go. I don't know if the host, if we're going to be doing questions at all. It looks like we might have time for one. I haven't seen any come in via the chat.
Yeah, Davis, thank you. We haven't seen any questions come through. My only question, Calvin covered there at the end with how can we get involved either locally or nationally, and so great insight there. I think one of the things that really stood out is the point you made about unless you're involved in home care, you've been in a home or been part of this, it's hard to kind of conceptualize what we do out in the field. And so really that ride along idea, I think, is really interesting. So great suggestions there. And we do have representation coming to the NOC Advocacy Day next week, myself included. I think there'll be 4 of us total from Idaho. So I'm looking forward to hopefully seeing each of you guys in person next week. But I wanted to, again, thank each of you for your time, your preparation. As an agency provider myself, administrator, I'm on the edge of my seat. These updates are really helpful. I get your emails. I'm on all of your lists. I think locally we try to share, information with our local senators and people that can cause change for us on the legislative level. So anyway, thank you for your preparation and your presentation and all that you guys do at your organization to help represent our industry. So thanks again.
Thank you to everyone. Yep, everyone who joined today. Keep up the good work.
All right, everybody. We're going to take a quick break, and between our next session, we'll probably be a minute late. We're not going to have a 5-10 minute break like you have. So give us another minute or two, and we'll be on with our next presenter. Thanks, everybody.